Hello everyone. So today we are going to learn about the elbow joint, how the musculoskeletal is correlated with the physiotherapy competence exam in Canada. So this is the topic that I want to discuss with the students so they know what to do, how to prepare themselves for the PC. We have a few students, so bear with me and then we will begin. Hi, Urvi. Urvi, are you able to hear me? Okay, perfect. We are gonna wait for. I'm good, Urvi. We are gonna wait for the few students and then we will start.
Right.
Hi, who's this? iPhone. Who's this? iPhone. We are gonna wait for few students and then we will start. Okay. Hi, Rajvi.
Hello,
How are you?
I'm good.
Good, good. Hello, Brunmai.
Hello, ma'am.
Okay, so let's start. Today is just a demo lecture, but it is a good topic. Small and they give you the idea that whenever you are preparing for the PCE, particular joint, how you gonna prepare. So basically, I'm just giving you a rough idea first. Whenever you are preparing for the physiotherapy competence exam, books is your best friends. No doubt my PPTs are really helpful for you guys. But as a student, I always suggest go with the book and then go with my PPT. Okay. Now the question is which book? So the book is Ishnar. That is a very, very important book. We have a Maggie. Very important. Therapy Ed. So these are the basic book regarding your MSK. And then most important is my PPTs and lecture. So if you are preparing yourself, you are going with this way. So go with the lecture first. So then you get the idea what to read, how to read, and then open the book. So it is easiest way to enroll yourself with the particular joint. Okay. So this is a question regarding the book. Now another question is what are the topic they're gonna ask in the elbow joint. So in terms of topic, in the elbow joint, basically, first of all, you should know about the arthrokinematics. Actually, sorry, I don't know who is at iPhone. May I know the name, please? Sorry?
Mayuri.
Mayuri. Oh, hi, Mayuri. Okay.
Hi.
Okay. So regarding the topic, in the elbow joint, they are asking about the arthrokinematics, mobilization. It is very, very important topic. What to do with if you want to improve the flexion, in which direction you are giving the glide. What is your grade? For example, for the pain, what is your grade? To improve the range of motion, what is your grade? So that way they are asking. Another thing is after mobilization, the conditions. So conditions are most favorite is tennis elbow, golfer's elbow, pulled elbow, myositis, ossification. So these are the small topic. They are asking about the identification of the topic as well as the rehabilitation. Okay, so this is the very important one. Another thing is carrying angle. Sometimes they are asking carrying angle, supracondylar humerus fracture, and peripheral nerve. So at the elbow, which nerves are supposed to be involved? All the three nerves, median, ulnar, and radial. All the nerves, median nerve at the pronator teres syndrome, radial nerve, basically radial nerve has a 5 component. One is a supinated one, ulnar nerve under the medial condyle. So this is the very important tunnel. In that one, ulnar nerve is a high chances to compress. Peripheral nerve is a different topic actually. In that one, there is a, I'm going to conduct the peripheral nerve injury. In that one, I'm going to take the nerve circulation, like nerve supply, muscle supplied by that nerve, the nerve root cause, what are the chances where they are compressed, and what are the signs and symptoms, and what are the rehabilitation. So that is a different topic. We will cover a little bit, but this is the way you have to read. Okay, so this is all your elbow joint. And if you go through the questionnaire, you are getting all these things. Arthrokinematics, mobilization is a separate topic, but particularly for the elbow, took movement, flexion and extension, conditions, and the peripheral nerve. Okay. If you have any doubt, you can ask me right away. So basically, whenever you are preparing for yourself, for particularly joint, you should know joint structure. Okay. So regarding the joint structure, what is the moving bone? So in the elbow joint, okay, so for example, I am going with the shoulder joint. Shoulder joint, scapula. So this is the portion of the scapula. Scapula is fixed and the moving bone is humerus, which is convex in nature. So that portion, student must know that what is the moving bone. Okay. Now, in terms of arthrokinematics, very little you have to know. One thing is moving bone. Second thing is direction. Third thing is resting position. Fourth thing is close chain position. And last is capsular pattern. Okay. Moving bone. So for example, shoulder joint, moving bone is the humerus. In the elbow joint, we have a 3 joint: humero-ulnar, humero-radial, and superior radio-ulnar. We will discuss, but 3 joint. Okay. So which is the moving bone? So basically, humerus is fixed. In the humero-ulnar, if I'm talking about the humero-ulnar, I'm just giving the figure. Okay, so in the humero-ulnar, the ulna is the moving bone and the surface of the ulna is concave. In the humero-radial, again, head of the radius, it is like this. But this surface, this is concave. So humerus is convex. The head is concave. At the humero-radial, again I repeat, humero-radial, the moving bone is the concave. Again it is concave. Okay, so humero-ulnar and humero-radial, it is the moving bone is the concave. While now this is the head of the radius and this is the ulna. Now this is your superior radio-ulnar joint. In that one, radius is the moving bone and the radius surface is convex. Okay, so this is the important thing that you should know, which is the moving bone in your joint. And now why we are discussing this thing? Because anyone has idea what is the concave or convex rule? Brunmai?
Yes, ma'am. In concave convex rule, if the concave is the moving part, so the movement would be in the same direction.
Very
And
good.
if in case convex is the moving parts, then the movement would be in the opposite direction.
Very good. So the thing is, so this principle, we are using it for the mobilization. Okay, so in the humeroradial, humero-ulnar, if you want to give the mobilization, you are giving in the same direction because the moving bone is the concave, while the superior radio-ulnar, the movement is supination and pronation, where the moving bone is the radius. That's why you are giving in the opposite direction. So this is the one point applicable to every joint. If you are preparing yourself for the shoulder joint, you should know elbow, wrist, hip joint, knee joint, ankle joint, any joint. You first identify which component is moving. If it is concave, you are giving glide in the same direction. If it is convex, you are giving glide in the opposite direction. Now the second point is arthrokinematics again, resting position and the closed chain position. So always we are giving mobilization in the resting position of the joint. So every student must know what is the resting position, because this position joint is open. You can give mobilization in a proper direction with the proper way. While closed chain position, it is the avoid. You should not go with the closed chain position, which is bone to bone eruption. After that, there is the chances of dislocation. So for prevention of the dislocation, you should know the closed chain position, and to giving the mobilization, you should know the resting position. So this is the another point. And the arthritis, in that one, you are getting the capsular pattern. Every joint has the different capsular pattern. If you in my introductory lecture, I asked about the capsular pattern of the shoulder joint, which is external rotation is more limited than the abduction, than the internal rotation. If I'm going with the elbow, flexion is more limited than the extension. That is the capsular pattern. Okay, so you have to prepare this thing. Then we are going with the joint conditions related to each and every joint. Peripheral now associated with that. And if it is elbow, what happened with the shoulder and what happened with the wrist. That correlation you should know. So this is your preparation. Okay. And in that one, throughout the whole chapter, you are good with the Krishna. In the Maggie, you're gonna read the arthrokinematic, applied anatomy. So that gives the idea that what is the clinical scenario. That if patient coming with the factory job and having a repetitive work, so this patient has the muscular involvement rather than the trauma history. So Maggie gives that clinical idea and then special test. For that you are using the Maggie. In the Maggie, same elbow joint, later portion of that chapter, you have a peripheral nerve involvement in the elbow joint. It is a very well explained in that book. So you can go that one as well. So this is your how to prepare. So far good? Any question? Okay. Let's go with the elbow joint. Elbow joint is a complex joint. I'm just gonna explain you about the PC point of view. So in the elbow joint, basically the trochlea portion of the humerus, which is convex, articulating with the trochlear notch of the ulna, which is concave in nature. Capitulum, which is convex, articulating with the concave surface of the head of the radius. That is your second joint. Third joint is proximal radioulnar. So you can see the head is the convex. So proximal radioulnar joint. And the distal radioulnar joint is not the part of the elbow joint, but it may involve for the supination and pronation, and that way it affects the mobility of the proximal radioulnar joint. Okay, so this is the fourth joint. Let's go with the detail. Humeroulnar. So every joint you should know about the resting position, closed chain position, and the capsular pattern, because that's what we have, like we required for our exam. So humeroradial, again, humeroulnar, again, humerus is convex, moving bone is the concave, ulna is the moving bone. Function, it takes the participation for the elbow flexion and elbow extension. Resting position of humeroulnar is 70-degree elbow flexion and 10-degree supination. So 70-degree. So this is my 90, 70-degree and 10-degree supination. That way you are gonna prepare for mobilization. So resting position of your elbow humeroulnar joint is 70-degree elbow flexion, 10-degree supination. Closed pec position is full extension and supination. Your ulna is locked with the humerus. And capsular pattern is flexion is more limited than the extension. So this is your arthrokinematics of humeroulnar. Humeroradius. Again, concave portion of the radial head attached with the convex humerus. In that one, again, now see, flexion and extension, that is the movement of the humeroradius. But humeroradial resting position is extension and full supination, which is the close position for humeroulnar. So this is little tricky. Which joint you are giving the mobilization, that is important. If you are giving ulna, 70-degree flexion, 10-degree supination. If you are giving humeroradius, full extension, full supination. And closed chain position of the humeroradius, elbow 90-degree flexion and supinated 5 degree. So this is opposite than the humeroulnar. And capsular pattern is flexion is more limited than the extension. Clear this portion? Any question, Urvi? Murunmai, any question?
No, ma'am.
Rajvi, Mayuri? So far good?
No, ma'am. Yes.
Okay. So now this point, humeroulnar and humeroradial is responsible for elbow flexion and elbow extension. Now in the exam, if you come across with a question having a Mr. Roy, for example, Mr. Roy has limited elbow flexion with 90-degree flexion and 0-degree extension. There is a form and fill. They are asking and fill as well. What is the mobilization in this scenario? They are asking the end fill at the elbow joint. It is the soft end fill. But right now, therapists fill the form and fill. Okay. So and fill is also another topic I will come across. But right now, let's just discuss the elbow joint. So the form and fill is there. That means there is a chances of the increased range of motion. Now, if you want to give the mobilization, which direction you are giving the mobilization? An option is anterior glide to humerus at humero-ulnar joint. Second option is anterior glide to ulna at distal radio-ulnar joint. Third option is anterior glide to ulna at humero-ulnar joint. Posterior glide to radius at humeroradial joint. What is your answer?
Anterior glide to ulna at humero-ulnar joint.
Anterior glide to the ulna, humero-ulnar joint. Why you are not choosing the third and fourth glide?
Ma'am, because first is anterior glide to humerus, but the moving bone is the ulna. So we cannot give to humerus.
Okay, go ahead, another.
Then anterior glide to ulna at distal radio-ulnar joint, but the movement takes place at the proximal radio-ulnar joint. So distal we cannot give. And last is posterior glide to radius at humeroradial joint. So posterior glide would be for extension, because we are dealing with flexion, it should go with the anterior glide.
Perfect. Everyone good? Rajvi, Mayuri, Urvi. So now this is the technique. You should choose the proper answer, but you should know why other three are not correct. Okay, because right now you are preparing yourself for the PC. So this is a very simple question. It is a like basic question, but I'm just giving the idea that if you are getting any question, whenever you are preparing yourself, you should know how to read the question first of all. So what is the keyword? So keyword is the 90-degree flexion and form and fill. That is your keyword. And then why it is the correct answer and why it is the wrong answer. Okay. So for the flexion, we are giving the anterior glide, ulna to the humero-ulnar, radius to the humero-radius. But the resting position is, Rajvi?
Yes, ma'am.
For the humero-ulnar, resting position is
70-degree flexion and 10% the supination.
10-degree supination. So you are giving anterior glide to the ulna at 70-degree flexion, 10-degree supination to the humero-ulnar joint. Clear? And the same thing, anterior glide to humero-radius, anterior glide to the radius at humero-radial joint with full extension, full supination. Clear, Mayuri?
Yes, ma'am.
Perfect. Same way, posterior glide. Again, you are using the resting position and the ulna and the radius. So depending according to the joint. Now the third joint is superior radio-ulnar joint. Superior radio-ulnar joint is the pivot joint. Here, convex head of the radius connect with the concave radial notch of the ulna. Supination and pronation is the prime duty. Resting position of the superior radio-ulnar is 35-degree supination, 70-degree flexion. So that means humero-ulnar, the resting position is 70-degree flexion plus 10-degree supination. while superior radioulnar resting position is same 70-degree flexion plus 35-degree supination. That portion you have to remember. And the remaining joint is the humeroradius. Full extension plus full supination. Clear? So you are giving mobilization in this position according to the joint. Now the third thing is close peg position is 5-degree supination for the superior radioulnar joint, and capsular pattern supination and pronation equally limited. So these are the three basic things: resting position, close check position, capsular pattern, and mobilization. This thing you have to have like thorough idea. And now to improve the supination, which direction we are giving the glide? What glide should be given for the superior radioulnar joint if the goal is to improve the range of supination?
In opposite direction?
Yes. So which direction you are giving the glide? Volar or dorsal? So volar is the palmar aspect and dorsal is the back aspect. Good.
Dorsal.
Perfect. So supination, we are giving the dorsal glide. Clear? Perfect. Hello, Ravinder.
Hello, Mamta.
Hi.
Sorry
So
for
we just-
joining late.
That's okay. We are just finished the arthrokinematics of the elbow, contain the
Okay.
humeroulnar, humeroradial, and superior radioulnar joint.
Okay, fine.
We are moving forward with the conditions and the topics which is related to the PCE, and you have to read through the book. So the first
Okay.
is the normal thing, carrying angle of the elbow. What is the carrying angle of the elbow? Anyone? So basically carrying angle of the elbow is whenever the long axis, the line joined between the humerus and the long axis of the forearm. Okay. So between the long axis of the humerus and the long axis of the forearm, the line which is joining, and then whatever angle is created, that angle is known as carrying angle of the elbow. In the male patient, it is 5 to 10 degree. Female patient is always more 10 to 15 degree. And one reason is wider pelvis. And basically if the angle is more, that is called cubitus valgus deformity. If the angle is less, it is called as the cubitus varus deformity. The angle is formed because of the trochlea of the humerus, which is slightly longer than the lateral side. And that is the reason that when you are going with the full elbow flexion and supination, angle is disappear. But if you are going with extension, angle is again reappear. So angle is appear with extension and supination and disappear with the pronation and the flexion. Okay. So this is one characteristic. Generally, you are not end up with the question here. It is the basic knowledge about the carrying angle. Some scenario. For example, supracondylar fracture of the humerus. Generally, cubitus valgus. It's mostly seen in the ladies, but cubitus varus is a rare deformity, and it is appear in the supracondylar fracture of the humerus, and that is called as the gun-stock deformity. So gun-stock deformity is mainly found with the supracondylar fracture, and therapists generally try to prevent this deformity. So we are responsible for that. and this is your basic knowledge. I didn't see any like frequently asked questions, but this is the basic that you should know. Now, moving forward. So again, we are just going with the normal ligaments. So particularly at the elbow, we have medially, it is called as the ulnar collateral ligament, laterally, radial collateral ligament, and there is one more ligament is called as annular ligament. Okay, I am saying always ulnar collateral and radial collateral at elbow because generally students are confused if I am saying medial collateral ligament, which is portion of the knee joint. Okay, so we will discuss medial collateral ligament, like we are pronouns, medial collateral ligament, lateral collateral ligament when we are discussing about knee joint. But right now, elbow joint, you always try to remember like this way: ulnar collateral, which check the valgus stress, radial collateral, which check means stop the varus stress on the elbow, and the one more important ligament is the annular ligament, which holds the radius head in the proper position. Okay, so it holds the radial head into the radial notch of the ulna and allow the radial head to slide against the notch and pivot to provide the supination and pronation. So this is basic. This is more than enough. Another one thing is triangle. So they are asking about the triangle of the elbow, which is disappear or disturb during the fracture time. And the triangle of the elbow is olecranon process, radius, and the ulna. So read, it is given in the questionnaire, just triangle. So triangle is disturbed because fracture happened. So alignment is disturbed and that disturb the triangle of the elbow complex. Let's go with the question. So question, it is also the basic question generally, but how to read the question, there is a technique. Father coming with a referral for 4 years old child. So whenever you are going with the PCE question, that is a strategy. The first strategy is age. Always identify. In my question, what is the age of the patient? So here age is 4 years, which is a pediatric. According to that, you may have ethical questions about the consent, about the child abuse. So these are the ethic portion, but you may end up with that question. So always see the age, who is coming with father, what is the symptoms, pain and swelling at the elbow, history is the keyword, swinging and hanging with the straight arm. So father coming with the children, pain and swelling is still present, and history is swinging the arm. Now the another point is the referral refers for pulled elbow. So already he went to the physician, which is very important in Canada. You already have the physician referral. So physician told the father, go to the physiotherapist. So you have a referral, you are good to go, there is no red flag. Second thing is already diagnosis is done, pulled elbow. Okay, so this is the way you are reading the question. And now what is the possibility at the joint? So basically, humerus, radius, and ulna. So radius is slip out from the annular ligament. So basically when father pulled the elbow, radius pulled inferiorly. So inferior subluxation of the radial head from the annular ligament. That is your correct answer. Now, right now you are all preparing. So why other three are not correct? First is superior subluxation of ulna from the annular ligament. Annular ligament does not hold the ulna. Out. Another out is annular ligament does not hold the ulna. So easy. Now B and the D. Superior subluxation of the radial bone. Superior means it pinch with the humerus. So this is not the subluxation. Subluxation is always on the downside. That's why your option is 4. That way you have to prepare. So this is a mechanism. You easily see that father holding the children at the wrist joint. So what happened at the radial head? Generally, the radial head pulled inferiorly from the annular ligament. Structure, basically the radial nerve is involved. What is the possible of the ligament? On the radial side, there is the first ligament is annular ligament, and another ligament possibility is radial collateral ligament. Okay, and initially there is a pain, swelling. Basically, physician does the close reduction, elbow maintained for the immobilization for few weeks actually, and we are going with the treatment. So this is your question in your exam. Identification. Here they already told you that patient having a pulled elbow. But same scenario, and they say what are the suspected diagnoses? Pulled elbow, tennis elbow, golfer's elbow, or the what I can say, distal radioulnar subluxation. So you have to identify what is the condition. They may give you the mechanism or the what exactly happened in the pulled elbow, or they may ask about the treatment. Okay, so generally I'm this treatment. So this is all considered as the soft tissue. Annular ligament is weak or the leg relaxed, head is pulled out, there is no fracture. So these are all condition is called as the soft tissue rehabilitation. Soft tissue rehabilitation always divided. Any rehabilitation, basically in MSK, any rehabilitation is divided into the 3 components. First component is known as maximum protection phase. And you must read from the questionnaire any joint if you are preparing, maximum protection phase is the important phase because that is the precautionary phase and therapist is responsible for it. Okay, so that is the important point. Then patient come with the moderate protection. I can say subacute. So first is acute, so third is a subacute, and the third is the return to function. So these are the 3 phases. Generally soft tissue. Every phase is 2 weeks. So 6 weeks, that is the general, every patient to patient it is different, but it is the generalized terminology. Soft tissue rehab is 2 weeks. If there is a surgical rehab, 4 weeks. Okay, 4 to 6 weeks is maximum protection, 6 to 12 weeks is moderate protection, and 12 weeks onwards return to the function. That is a surgical. If it is acute, you are going with the 2 weeks. So you tell me, if I am your patient, for example, I am coming with a case of the pulled elbow. Okay, or any acute case. For example, I have a ligament sprain. Okay, that is also the soft tissue. First treatment in the maximum protection phase. What is your first treatment? Question to Rajvi.
Ma'am, maybe splinting or
Splinting. Okay.
ice pack.
Ice pack. Then
Patient counseling.
okay. Anyone, anything, if you want to add?
Ma'am, right, rest, icing, compression, and elevation.
Very good. Actually, price, not rise. Protection, rest, ice, compression, and elevation. So price protocol is the first protocol for the maximum protection phase. Here, therapist is responsible to identify the contraindicated movement. So I'm just giving the rough idea, okay? Indicated movement. So pulled elbow, there is no contraindicated movement, but some, for example, shoulder subluxation. So here we are not giving abduction and external rotation. So that movement, you have to educate the patient. You should not do this movement. So controlled movement, contraindicated movement, therapist should know and educate to the patient. Price protocol protection in terms of the sling or the splinting, rest, ice, compression, and elevation. And any soft tissue injury for the upper limb, therapist must prevent complex regional pain syndrome. So this is the CRPS or the reflex sympathetic dystrophy, RSD, which is the sympathetic stimulation, and basically patient having a symptoms at the wrist where there is not actually problem. So therapist is responsible to prevent the RSD, and for that we are giving elevation and the gripping exercise. So this is your overall maximum protection phase. Third thing is, as soon as, so now why I am giving all these things? So my goal is to prevent swelling and pain. To reduce the pain, to reduce the swelling, it's my first priority. So for the swelling, elevation, for the pain, compression, ice, okay? Now, second thing is, as soon as swelling is decreased, as soon as pain. So here again, for the pain, you can give grade 1 mobilization, because grade 1 mobilization is the small amplitude rhythmic oscillation used for pain relief. So you may end up with the question that patient having a pulled elbow or the tennis elbow or something soft tissue injury. It is the first week. Swelling is getting down, but patient still has the pain. What is the best approach in this scenario? So here grade 1 mobilization is just distraction. It is not any direction. It is helpful to reduce the pain. Okay, so that is overall thing. Once pain is reduced, range of motion is improved, patient is done with the 2 week. Another 2 week, we are good to go with mobilization. Here we are good with grade 1 or 2. We are good with the range of motion. So initially on the acute phase, also we are good with the active assisted or the P-ROM. And then subacute phase, we are going with the active range of motion. And at the end of second phase, so approximately 4th week, then we should start stretching. So stretching is not the earlier rehab. And then return to the function. What is the patient's requirement? If patient is computer worker, 90-degree elbow flexion is functional, we achieve the normal range, good. But if patient is athlete, he is a throwing athlete, he needs the plyometric training, he needs BNF training. So that way you gonna go. So this is your generalized soft tissue rehab. Any question? So depend on the question, you have to choose the answer. Okay. Now we are going forward with the question. Let's go with the question. Let's go with the question. 40-year-old man. So again, age is the important factor you have to identify. Having a pain in the elbow since 3 months. So this is not acute pain. It is the chronic pain. Okay. So 40 years, 3 months, he has the pain. Upon examination, pain is increased with passive range of wrist flexion and ulnar deviation. Pain is increased with active wrist extension, radial deviation. So they are giving two symptoms, clinical scenario. Okay, so imagine in front of you, I am your patient and I have the same problem, wrist flexion. So if you do passive wrist flexion and ulnar deviation, my pain is increased. If you ask me to do the active wrist extension, I have a pain. I'm not going with the answer right now. Let's discuss the conditions. So most of the time, whenever in your question, so right now in the Canada, the PC evaluate your knowledge, okay, through the question. So here you have to think about the clinical picture of the patient. When patient comes to you, for example, say, I have an elbow pain, and whenever I am coming to you, questions to the Ravinder, I'm coming to you with my elbow pain. So what thing you gonna go first?
History, first thing.
Sorry?
Start with the history of the
History.
pain. How the
Then?
pain started, and after that we have history, pain history, and then you have to go for the observation of the signs and symptoms like swelling, and then palpation. Palpation, tenderness, again swelling, in palpation, tenderness, swelling, and then examination.
In the
Range of
examination, what are you
motion,
gonna do?
range of motion,
By performing
active range of motion, passive range of motion, and MMT, manual muscle testing, and then special tests
Very good.
related to that joint.
Almost correct. Observation, very good. So almost correct. Whenever you have a patient, clinical picture. So basically, general information, orientation to the patient, history, how this is happened. So mechanism of injury, that is your keyword in your question. Third thing is previous history. This is very important, this point. Do you have a same pain before? Or in that question, so like in your question, patient has the history of trauma 11 years ago, 10 years ago. So that type of the patients are more prone to the arthritic changes. So if you have a previous history of injury, that is important to note down. Then you are thinking, okay, let's see in that question, swelling, cut, bleeding, joint texture, posture on observation. So posture is important in MSK. Basically, not for elbow, but for shoulder joint. If patient having a kyphosis, they end up with impingement syndrome. So correct the kyphosis, you can correct the shoulder joint. So that way posture is important. On palpation, 3T, tenderness, tightness, and the tone. In MSK, tone is okay, but generally tenderness and tightness. Tone is only problematic when there is a nerve injury, peripheral nerve injury. Sensation. Sensation is always first to assess before the muscle. And if there is a scar texture, healed, not healed, that way you're gonna go. On examination, main thing is you have to think which active movement is painful and what is the end feel. If elbow joint soft is the normal end feel, but if patient has the empty end feel or the firm end feel or the hard end feel, all is considered as the abnormal end feel. passive range of motion. Now the another thing is RIMS, registered isometric movement. Now, do you know what is registered isometric movement? What is the importance of RIMS?
Ma'am, it is divided into weak and painful, strong and pain-free, strong and painful, and weak and painful.
So what is the importance of these four?
So with this, we can identify the structures involved. For example, if it's strong and pain-free means there is no kind of muscle injury. But if it's weak and painful, so maybe there would be due to any structure involved like fractures.
Got it. Good job. So this is the important thing. Now let's discuss. If I'm coming with you, my elbow is painful. You are asking me, Mamta, do the flexion. If I say flexion is normal, extension, normal, you check my wrist joint, wrist flexion, active movement, painful, wrist extension, active, painful. So I gave you, okay, now let's see, be with me. So all the elbow movement, not painful. Active range of motion, sorry. So this all elbow active range, wrist, flexion, and extension, both are painful. Okay, now once active is painful, means muscles and tendons are involved. Only passive is painful, then it is a stretch pain or the ligament pain or the bursa is involved, meniscus is involved. Okay, so active and passive both are involved. That means it is bursa. That way you have to identify the structure. Now you are checking my, again I'm coming with the elbow pain. Active wrist flexion is painful, active wrist extension is painful, but passive wrist flexion is painful, passive wrist extension is pain-free. So active and passive wrist flexion extension is painful, passive wrist flexion is painful, passive wrist extension is not painful. So now I have two things. Passive wrist extension is pain-free, but we have to go with the active wise. Active is painful. So whatever passive is not painful, active is painful, that is the point of problem actually. Now I will explain you why. What is this scenario? Anyone? This is a scenario case of pulled elbow, tennis elbow, golfer's elbow, or the just elbow strain. So I'm giving you the clinical scenario. I'm coming with you, elbow pain, active wrist, no active and passive elbow movement is painful. But active wrist flexion, active wrist extension, both is painful. Passive wrist extension is pain-free and passive wrist flexion is painful. What is this scenario? What is the condition actually? It is a wrist sprain or it is the elbow problem. What is the problem here? Anyone? So this is a condition of tennis elbow. We will discuss what is the tennis elbow. But just keep in mind. So this is the clinical scenario. Now you are suspected that MAMTA has something problem with the wrist flexor or extensor. You don't know which muscle is involved. Okay. So at that time, you are going with registered isometric movement. So registered isometric movement is divided into the 4 results. Okay. So elbow flexion extension is good. So no need to check the elbow muscles. Now wrist flexion extension, active, passive. Passive is not painful, but active is painful. So you are going with wrist extensor, hold and relax. So this is your technique. You are asking me to do the wrist extension and you are just giving the hold and relax. So this is called RIMS, registered isometric movement. And at that time, patient shows strong contraction but painful. So strong and painful, which is indication of the minor lesion of the tested muscle. And what is the tested muscle? Common extensors. And common extensor is originated at lateral epicondyle. That's why it is a case of lateral epicondylitis. Clear? Another RIMS. So now we are checking my wrist flexors. So if I am doing isometric wrist flexion, strong and painless, I don't have pain. So there is no problem. It's normal. Another two, if weak and painless. So patient has a weak contraction and there is no pain. That is indicating of nerve involvement or complete rupture of the muscles, or there is a disuse atrophy. And the fourth is weak and painful. That is the fracture case, tumor, partial rupture, inflammation. So you have to identify where my patient is, whether he is the severe or within our scope of practice. If patient has a weak and painless contraction and he did not go to the doctor, you have to refer to the physician first. So that is the Canadian ethics. If patient has a red flag, refer to the physician. If they have no red flag, good to start the treatment. Clear? Any question? So far clear?
Yes.
Okay. Now, what is lateral epicondylitis? Let's discuss that condition in a separate topic, because this is very, very important condition, frequently asked question. Day-to-day life, patients are end up with the lateral epicondylitis. So what is lateral epicondylitis? For me.
Ma'am,
Yes,
ma'am, what was the answer of that last question?
we will come back that question, I know.
Yeah.
So what is lateral epicondylitis? First of all, so we have at the elbow, we have a two epicondylitis. One is the lateral condyle inflammation, it is called lateral epicondylitis. Another one is the medial epicondylitis. Any idea? Murun bhai, what is the lateral epicondylitis?
Lateral epicondylitis means the common extensor tendon origin is from the lateral epicondyle, and due to heavy activities or constant extension, this get inflamed. So itis means inflammation of the tendons, and therefore they get chipped off from the elbow, and the patient might have symptoms like pain and swelling.
So what is the symptoms? Pain. Pain location is
Lateral epicondyle.
lateral epicondyle.
Then any kind of wrist extension would be painful.
Any kind of wrist extension is painful. Okay. So now let's go with the clinical scenario. Which active movement is painful?
Active wrist extension.
Which passive movement is painful?
Wrist flexion.
Now everyone. Okay, everyone does. For example, wrist extension, common extensor origin is painful. So if you are doing active wrist extension, it is painful, understood. Now do active wrist flexion. Do you feel little stretch at your lateral epicondyle? What is this active wrist flexion? Controlled lengthening of extension muscles. I can say like that. I can say when I am doing wrist flexion, there is a lengthening of extensor muscles. I can say like that.
Yes.
So active wrist flexion is also painful because at that time there is a pulling effect. So if patient goes full flexion, some degree, it is not extreme painful, but some degree I can say active wrist flexion is painful. But what happened with the passive? So passive opposite direction, again it is a stretch pain, painful. But when I am doing passive wrist extension, is it painful or it is painless or painful? Passive wrist extension.
Pain-free.
It is
Pain-free.
painful. Because now muscle is not moving, some other does the movement. So muscle is not contracting. So this is pain-free. Okay. So this is the important thing to identify lateral epicondylitis. Now let's go with this question. 40-year male, 3-month chronic problem. Upon examination, passive wrist flexion and ulnar deviation, active wrist extension and radial deviation. So here the answer is lateral epicondylitis. Medial epicondylitis. What is the scenario here? Which active movement is painful?
Flexion.
Flexion and pronation. Because pronated teres is also getting originating from the medial epicondyle. In the tennis elbow, the radial deviation is painful. Okay, so this thing just remember. But in the medial epicondylitis, pronated teres is important muscle. So pronation and wrist flexion, they are more involved. So active wrist flexion, active pronation painful, passive wrist flexion, passive pronation is not painful. Clear this point? Or confused?
Ma'am, can you please tell me?
Repeat. Okay. See what I am saying, medial epicondylitis. So medial epicondylitis is the common flexor origin, wrist flexors actually. So in that one, active wrist flexion, and here also one muscle, pronated teres. It is originating from the medial epicondylitis. So pronation, that is active, is painful, but the same moment, wrist flexion and pronation, if I am doing passive, so some other therapist does, muscle is not contracting, so it is not painful. Clear? Or still confused?
No, ma'am. Clear.
Clear? Now, opposite. So wrist extension. Okay. So wrist extension at somewhat degree, active is painful, I can say, because there is a stretching effect happen to the wrist flexors. But passive wrist extension is 100% painful because it is a stretch effect. So that is your medial epicondylitis. Now another two options, ulnar collateral ligament sprain, radial collateral ligament sprain. Actually the location is elbow and pain is also with the elbow movement, elbow flexion extension. Wrist is not involved in ulnar and radial collateral ligament sprain. Okay, so that way your answer is 3. Okay, let's go with the condition. So medial versus the lateral epicondylitis, both overuse syndrome, those who are factory worker, those who are working in the like tea mortons or any of the coffee shop or in the restaurant, or they are going with the, you know, the dishwashing, they have to do the repeated work of the wrist, and repetition leading to the overuse and syndrome. Any epicondylitis, there is no neurological involvement. It is pure muscular. Very, very important word. Same patient having a tingling numbness in the forearm. So this is not epicondylitis. There may be a chances of the ulnar nerve compression. Okay. So this is important keyword for differentiating condylitis versus the neurological involvement. DD, same DD I told you. For the medial epicondylitis, active wrist flexion is painful. Wrist extension, passive and active, both is painful. Radial deviation, active and passive, both is painful. Ulnar deviation, only active is painful. And pronation, active is painful. Same way, lateral epicondylitis, overuse syndrome, wrist flexion, active and passive, both is painful. Ulnar deviation, active and passive, because it is opposite movement, both are painful, but the same direction. Wrist extension and radial deviation, only active is painful. Any question? You got the picture, like clinical picture, that patient coming with the elbow pain. You have to differentiate lateral epicondylitis versus the medial epicondylitis. Clear? Now, you may end up with this question. Lateral epicondylitis, which are the main muscles? So ECRB, extensor carpi radialis brevis. This is the most common muscle is involved. Other muscles are extensor carpi radialis longus, extensor carpi ulnaris, extensor digitorum communication. These are the main muscles which is involved with the lateral epicondylitis. And medial epicondylitis, main muscle is the pronator teres, flexor carpi radialis, occasionally palmaris longus, flexor carpi ulnaris, and flexor digitorum superficialis. These are the main muscle for the medial epicondylitis. So the cause, overuse, symptoms, pain and swelling, active and passive movement is painful, but there is no neurological involvement. So you are going to check on history, on observation, location of the pain, on palpation, A room, P room, and rings. And then further, you are going with special test. I didn't put the special test. Oh, come on. Anyways, special test. What is the special test for lateral epicondylitis?
Cousin's test and long finger extension test.
That known as Mills test. So both are important. Cousin test and the Mills test. Identification, that gives the clear idea patient is confirmed diagnosed with lateral epicondylitis. Physiotherapy examination and physical assessment or physical analysis. That is your word. Diagnosis is not done by physiotherapist. That is ethics. Okay. So diagnosis is done by the physician. You are just going with the physical assessment and your assessment conclusion. That is your case. Lateral epicondylitis you can assess easily. So you don't need to refer to the physician unless and until there is no red flag. You can read the red flag from the Maggie. There is a table is always given in each joint. And this is the lateral epicondylitis theory is given in the Kishner. If you want, you can read it from the book. But generally, you end up with these questions regarding this scenario, okay, in the exam. So in the history, you have to take palpation, A room, P room, rims, and special test. Patient has a variety of the complaint. Some say, oh, I have a pain couple of the hours after the provoking injury. For example, mother having two children. One is the 2 years old baby and another is 6-month boy. So that boy is heavy and repeated lifting of that boy end up with a tennis elbow. So variety of the symptoms you may get, maybe faint pain after the work. Another one is immediately I lift, I have a pain. Third is during the work activity, I have pain, and once I stop the activity, still it is continue. And another is constant pain. Okay, there is no rest. So you may get any of the symptoms. It is not important. Like you just get the idea. Same way, medial epicondylitis, differential diagnosis with the medial epicondylitis that you should know. And now the treatment. So again, it is a subacute. So in the previous one, pulled elbow, I just say that immobilization. But here, again, 2 weeks, maximum protection, return to the, subacute and return to the function. So maximum protection. Price protocol. Price means protection, rest, ice, compression, and elevation. But here, orthosis. That is the separate topic in the in my lectures. But orthosis is two correlation with the elbow. If patient has a little epicondylitis, which orthosis you are giving?
Tennis elbow splint.
Sorry,
Tennis elbow splint.
where?
Over the muscle about 1 inch below the lateral epicondyle.
Over the elbow, right?
Yes. Below
What is the function of the orthosis?
It will transfer the weight to the.
Yeah, go ahead. Weight to the
Orthosis.
inward or orthosis. Okay. Any other?
It will reduce the compressive forces acting on the directly to the muscle, which is more inward.
So it reduces the compression force. So tennis elbow brace, which is where at the elbow, it supports the weak structures or the inflamed structures. It maintains the position. That is important. Another orthosis is you can give is wrist splint. Because the wrist, if it is move upward extension, it causing the activation of the muscles. So provide the rest, you are giving the wrist splint. Okay. So that is the another splint given in the Krishna. Rest the muscles by immobilize the wrist in the splint, such as the cock-up splint, in which elbow and fingers are free to move. So you maintain the wrist in the proper position, and then you are free to move the elbow and all these things. Okay, so be at cautious. Don't jump with the tennis elbow splint at the elbow. If you get the cock-up splint or the wrist splint in the tennis elbow, it is also good because it maintains the wrist in the extension position, prevent the stretching effect at the inflamed area. Clear? Okay, so this is the one point. Otherwise, I already explained. Maximum protection, RICE protocol, muscle setting. Okay, now what is the muscle setting exercise?
Isometrics.
Isometric. So how it is different than the isometric? If I am saying muscle setting exercise versus isometric, how it is different? Anyone? Isometric is the high intensity isometric exercise, while the muscle setting is the low intensity isometric exercise. So if I am giving full contraction, full resistance and the hold, that is my isometric. But 10% contraction and hold, that is my muscle setting. Always you are giving the muscle setting exercise in initial phase. Okay, so muscle setting exercise is important to protect the structure. Just a minute, go with my slide. Like just read and then I will ask you a question. So maximum protection phase, you are going with the RICE protocol, muscle setting exercise, cross fiber massage that you can give in the acute phase of the tennis elbow, wrist brace, and control motion and return to the function. I just combined it because as the patient progresses, you can good to go. Manual stretching, mobilization with the movement. But the first important point is always give eccentric exercise to the tennis elbow. This is your question. Eccentric exercise followed by the concentric exercise. This is your isotonic exercise. This is your isometric exercise. This is the part of the exercise, type of the exercise. Isometric and then isotonic. But in the isotonic, you are first going with the eccentric exercise. So what is the eccentric exercise here in the tennis elbow?
Wrist flexion.
So controlled wrist flexion. So you can ask the patient to maintain the 0 degree and then go with 90, again come back. So this is your eccentric exercise and then concentric. So concentric to neutral. So what you're gonna go, sturdy, maintain the elbow 90 degree, go with the 9 down, that is your eccentric exercise, come back to the neutral. So this is your eccentric, followed by the concentric. If patient is good, then make a whole arm, eccentric to concentric. If patient is more better, then change the angle. So slowly change the angle and go with the 0 degree. That way you are treating your patient. And then resistance exercise again.
Ma'am, but why eccentric exercise is followed after concentric? Like, should perform first. What is the clinical reason behind it?
Reason, okay. Anyone wants to give the answer? Sorry? Why we are giving eccentric exercise followed by the concentric? What is the answer, reason behind that?
Lever, third order.
Yeah, biomechanically, yes, we can say lever. But here, actually what happened, tennis elbow, there is a muscular problem. Inflammation is there. When you are giving controlled lengthening, there is a less damage to the muscle versus the concentric. So here patient fibers are spring. It is not rupture, spring. Okay, so it is like that. When you are giving controlled lengthening, it is not gonna damage to the fiber. But if you are going with the concentric exercise, it leads to the more damage. So eccentric exercise is a safer exercise than the concentric for the inflammation point of view. Clear, Murunbhai?
Yes, ma'am.
Okay, so eccentric exercise we always giving. And one more thing, whenever you are going with the functional movement, always we are doing eccentric. For example, in the upper extremity, whenever we are taking food to the mouth, so that is first we are doing eccentric. We are not doing concentric one. In the lower extremity, sit to stand. So that is also the eccentric, stand to sit, eccentric lengthening of the quadriceps. So functional movement, squatting, eccentric lengthening of the quadriceps. So whatever functional movement, we always require eccentric workout rather than the concentric workout. That's why eccentric is always first followed by the concentric. Clear?
Yes, ma'am.
Okay. Let's go. So this is your, okay. Stretching you can give at the end of the controlled motion, that is your subacute phase. So stretching you are giving to the extensor, so passive wrist extension. Mobilization with movement, they are not asking technique. So don't dig yourself with the technique. You are preparing yourself for the written exam. Eccentric exercise followed by the concentric, resistance exercise, and functional resume. So whatever patient do, you can go with that training. If it is athlete, you can go with the plyometric training or the cross-country skiing, that is the sports person. Again, as per the requirement, you are giving the high intensity exercise. So that is your overall rehab for golfer's elbow as well as the tennis elbow. Let's go with the question. Easy. During the examination of the elbow strength, using MMT, patients supinate the forearm when attempting the elbow flexion. Which of the following muscle is the most likely major part of the work? Always read this word, okay? Whenever you have a question. So this is a technique in the how to read the question. You are going from whole question starting to end and then read only the end question. So this is your technique. In that one, if there is a word most, unlikely, not included, except this word, giving you the idea that what to choose. Okay. Here is the easy question. When patient do the supination while doing the elbow flexion, it is the biceps. Let's go with the question now. So the question is, 40-year-old lady having a fracture of the distal humerus, sorry, it's my fault, distal humerus due to fall. She got close reduction, internal fixation, and having a cast for 6 weeks. Once cast is removed, she attended the physiotherapy clinic. Her range is 5 degree lacking in extension. Flexion is 20 degree. She attended for 3 weeks and does exercise regularly. At the end of the 3 week, full extension, 100 degree flexion. Due to the family reason, she is out. And now, again, she end up with the hard lump at the fracture site, pain with the bending, and she cannot straighten her arm. What will the next step for the PT for this condition at the elbow? First of all, tell me what is this condition? Name of the condition is?
Myositis ossificans.
Ossificans.
Myositis ossification. What muscle is involved in that one?
Bicep.
What's the biceps?
No.
No biceps. Like less chances, mainly brachial. Okay.
Okay.
Now I'm not going with the answer right now. Let's discuss the condition first. Myositis ossification and the heteropic ossification. Terminology almost similar, but heteropic means formation of the bone at the joint. That is called heteropic ossification or over the bone. Myositis means at the muscle. So inside the muscles, if there is a formation of the callus or formation of the bone, that is called myositis ossification. At the elbow joint, brachialis. So there is a two common muscles. One is the brachialis, another is the quadriceps. Okay, so these two muscles are highly involved with the myositis ossification. What is the mechanism? Why this is happening? So generally when there is a fracture, supracondylar humerus fracture or any fracture, bone is already healing, right? So callus formation is going on. But at that time, if patient end up with the too much stretching or there is a trauma to the muscles, what happened? Inside the muscle, blood vessels are ruptured. So muscles, basically, so just I'm giving the idea. So this is a fracture. Here the callus formation is going on. Overlying, there is a muscle. In this muscle, blood vessel is ruptured. So now blood inside the muscles attract the calcium ion. Blood attract the calcium ions towards them. So calcium ion from the fracture side, they are going to the muscles. Okay, and they start gathering to each other. That is called calcium deposition in the muscle. Initially, there is a soft lump, but if it is not removed, it converts into the hard lump. And once it is hard, it restricts the range. Surgical excision is removed, a must. Surgical removal of the callus is important. So in that one, myositis ossification, you are not giving vigorous stretching because it breaks down the muscle fibers, rupture the more blood vessels, and more calcium ion is deposited. Another thing that you are not giving is massage. Because if you are doing the massaging the part, massage increase the blood circulation. Third thing is complete rest. If you are giving rest, soft callus, whatever accumulate there, it not resolve. Okay. So now let's go with the question. Give the rest in the splint until the hard lump becomes smooth. If you are giving rest, there is no recovery. Gentle stretch with massage at lump site. Massage increase the blood circulation, deteriorate the condition. Fourth option, vigorous stretch. What happened? Yes, vigorous stretch without massage. But vigorous stretch again increase the blood circulation, rupture the muscles. So the answer is C, gentle stretch without massage at the lump site. Clear? Any question?
Ma'am, I had a doubt in mechanism. If we do the vigorous stretching, like how is the calcium deposition occurring between the muscle and bone? So I had a doubt.
See, that's what I'm saying. Patient has a fracture at the humerus, right?
Yes, ma'am.
So what happened? What is the fracture healing process?
The blood flow would be increased, and there would be calcium deposition, then a callus formation, and then the whole bone formation.
Good. So that happened at
Fracture side.
There is no involvement of the muscle.
Muscle.
But during the fracture, the patient is immobilized in the resting position, right?
Yes. Yes.
So that is a long period where the muscle is in the shortened position. So now muscle is in the shortened position here, this biceps muscle, biceps, brachialis or whatever. Okay.
Yes, ma'am.
Now you are giving stretching to that muscle because you want to increase the range.
Yes.
So when you are giving stretching, here you rupture the fiber.
Okay.
And that here increase the blood circulation. So inside the muscle, the blood circulation is increased. And now that blood attract the calcium. So calcium is already soft callus, already at the fracture site, but that redistributed toward the muscles. You got it?
Yes, ma'am.
Okay, so we have to prevent this one inside the muscle. Generally, brachialis is highly vascular muscle. That's why chances of the myocarditis ossification more in brachialis.
Okay.
Yeah.
Yes.
So management, you are not giving passive stretch, massage, any resistive exercise, because that also increase the muscle fiber contractions. It's contraindicated if the brachialis muscle is traumatized. Elbow should be kept in the rest in the splint, and it is removed during the exercise. Periodically is removed. Rest is continue until the bone mass is matured and reabsorbed. If convert into the hard bone, surgical excision is required. Another thing is you are not giving modality. Modality like the heat pack, cold pack, it also increases the blood circulation. So cold pack you can give because it is a vasoconstriction, but thermal modality is a vasodilatation. So vasodilatation again increase the blood circulation. We are not giving it myositis ossification. Clear, everyone?
Ma'am, means
go ahead.
any treatment which would increase the blood circulation, we should avoid in myositis ossificans.
Yes. So I told you give the active exercise. So why I am giving active exercise to myositis ossification patient? Any idea? Mayuri, Rajvi? Why we are giving active exercise to the myositis ossification patient?
Because stretching is not doing over there. So in limited range, only patient is moving their elbow.
Pain-free limit, would we say pain-free limit, we can go with the active range, but active exercise. So when active contraction happen, calcium ion, which is deposit inside the muscle, active muscle contraction help to loosen the iron. And once they are loose, they move out and there is no fixed deposit of the calcium. That's why active contraction is helpful to slowly remove the calcium deposition in the muscles. If we are giving with the passive, then muscle is not contracting and that end up with the stretching. So we want gentle active contraction to remove the calcium deposited ions. Okay, that's why we are going with gentle active exercise. Clear? Any question? Ravinder, good? Good, everyone? So these are the, yeah, Rajvi, any question?
No, ma'am.
Okay, so small topic. So if you are divide your elbow joint, how to read? Go with the arthrokinematics, humero-ulnar, humero-radial, superior radial-ulnar, resting position, closed chain position, mobilization and capsular pattern. Then you are going with the carrying angle, pulled elbow, ligaments of the elbow joint, pulled elbow, then tennis elbow, golfer's elbow, myositis ossification. Okay. Now, peripheral nerve. So peripheral nerve injury, it is a separate topic. I always took as a separate topic, but just right now we are at the elbow joint. What are the expected nerves which is involved in at the elbow joint, or there is a susceptible to injury at the elbow joint? So there are three nerves: medial nerve, ulnar nerve, and the radial nerve. All three nerves, on and off average, they are susceptible to injury at the elbow joint. Let's go with the question. Patient referred to the physiotherapy for the treatment of tenosynovitis, pins and needle sensation on the palmar surface of the thumb, index finger, middle finger, examination, positive tenal sign at the wrist joint, good opposition of the thumb based on this finding, patients suspecting medial nerve compression at the wrist, ulnar nerve compression distal to the elbow, tenosynovitis of the abductor pollicis longus, and thoracic outlet syndrome. So your answer is median nerve compression at the wrist. If median nerve, so at the elbow, median nerve has the chances to compress at the pronator teres. So between the two head of the pronator teres, median nerve is passed. If it is compressed at the pronator teres, so what happened? Basically, median nerve supplies pronator teres, pronator quadratus. The branch to the pronator teres. So, okay, this is the two head of the, so just I'm giving a rough idea, okay? Two head of the pronator teres and pronator quadratus. It is the horizontal muscles. Now the peripheral nerve, median nerve is passing here between the two head of the pronator teres. When median nerve is compressed between the two head of the pronator teres, the muscle supplied by the median nerve below the compression is getting the numbness, weakness, because they are not getting the signal. Okay, but branches to the pronator teres from the median nerve is above the pronator teres head. You got my point? So pronator teres is already getting its nerve supply through the median nerve before it enter into the pronator teres. But when it enter into the pronator teres, it compressed, it getting like lack of the nerve supply to the pronator quadratus. That's why patient's pronation is weak. Clear this point? Pronator teres is not weak. Pronator quadratus is weak due to the compression of the median nerve at the two head of the pronator teres. Clear this point? It's important point. Now regarding median nerve. So right now we are thinking about that the elbow. Median nerve supplies pronation. So responsible movement is pronation, finger flexion. So FDS and FTP, FDS and FDP. Thumb, all the thenar muscle. Except which muscle? All the thenar muscles except which is the muscle is not supplied by the median nerve.
Abductor pollicis longus.
Sorry?
Abductor pollicis longus.
Abductor or adductor? Adductor. Adductor pollicis, which is supplied by the ulnar nerve. Okay, so all the thenar eminence, flexor digiti minimi, extensor opponus digiti minimi, abductor digiti minimi, supplied by the median nerve except adductor. And that's why median nerve injury, the thumb remain with the palm and create the app hand deformity because this adductor is active. Okay, and that's why they are creating the app hand deformity. Clear? So adductor pollicis is not supplied by the median nerve. That is one thing. Sensation. So first three fingers, thumb, index, middle, and half of the ring finger, and the first digit. They are supplied by the median nerve. Sensory stimulus, sensory problem, patient having a tingling, numbness, burning sensation. All sensations are present in the distributed area. Now, another extraordinary thing about the median nerve is anterior intraosseous nerve. Do you know this now? Like anything idea about this now? Brunmai, anterior interosseous nerve.
Branch of median nerve.
Sorry?
Branch of median nerve.
Yeah. What is the specialty? It is only motor branch. So if anterior interosseous nerve is compressed, you are not getting any sensory complaint, only motor weakness. So the thumb is weak, grip is weak. Okay, regarding the median now. So again, because the peripheral nerve is a different topic, but I'm just taking only the elbow component. Median now, grip. There is a two type of grip in the hand. One is the power grip, which includes the spherical, cylindrical, and another is the prehension grip, which include tip to tip, pulp to pulp. So that prehension grip is supplied by the median nerve and power grip is supplied by the ulnar nerve. So always remember, median nerve weakness leading to the difficulty in prehension grip, ulnar nerve difficulty with the power grip. So that grip weakness, muscular weakness, but there is no sensory problem, that directly indication anterior interosseous nerve syndrome. Symptoms will appear distal to the compression and the weakness in the muscle of the anterior interosseous branch of the median nerve, such as flexor pollicis longus, pronator quadratus, FDP of index finger. Reduction in the sensory perception at the median nerve distribution will appear, but anterior nerve syndrome, it is pure motor. So there is no sensory distribution. If median nerve is compressed, yes, you get the sensory distribution. The technique is pronatatory syndrome, MMT assessment of the pronation, pinch grip test. So these are the special tests for the median nerve and tingle sign. So if you tap at the compression side, you get the tingling numbness. How to differentiate with the carpal tunnel syndrome? So carpal tunnel only at the wrist, pronation is not involved. Pronation is strong. Okay, but pronation is weak, means compression is at the elbow level. Wrist one, I'm not going to discuss right now. So only we are going to discuss this thing. It is a broad topic. Again, I'm saying it is not only end up with this. There is a muscle supplied by the median nerve. There is a rehabilitation, splint, orthosis, everything is involved. I'm not going right now with that. Main complaint, if the elbow joint nerve is compressed, sensory loss, sensation loss, patient wake up at the night, repetitive use of the hand, aggravate the symptoms, feeling of weakness, grip weakness, observation, atrophy of the thenar eminence, app hand deformity because of the adductor pollicis, and patient has the manipulation like zipping the activity, zipping the jacket or unzip the jacket or buttoning, that requires the prehension grip, that is weak. And if you go with the MMT, pronation is weak, wrist flexion is weak, thumb thinner muscles is weak. So MMT shows the motor weakness. That is your median nerve. Same way ulnar nerve. Same way ulnar nerve. So ulnar nerve is passing through the cubital tunnel, which is the most prominent on the medial epicondyle. So beneath the medial epicondyle, there is the ulnar nerve. It is known as the cubital tunnel. Floor is with the elbow capsule, posterior band of the medial collateral ligament, and ulnar nerve is superficial there. Long standing pressure leading to the ulnar nerve compression, or sometimes between the two head of the flexor carpi ulnaris, there is the ulnar nerve compression. The muscle is the ulnaris is weak, so ulnar deviation is weak, and all the ring finger. So digiti minimi, abductor digiti minimi, flexor digiti minimi, opponus digiti minimi, and adductor pollicis. This muscle is weak. Sensory, half of the ring finger, lateral half, and the ring finger, they are, sorry, medial half of the ring finger and the ring finger, little finger, sensation is affected, tingling, burning sensation. And you have to differentiate the ulnar nerve with the Guyon canal. where the ulnar nerve is compressed between the pisiform bone and the hook of Hammett. Symptoms are almost similar, only ulnar deviation is not weak. So that is the category of the ulnar nerve compression. Clinical presentation, weakness and atrophy of hypothenar muscles, Bischoff deformity. Bischoff deformity you will found in the Maggie, where there is a clawing of the ring finger and the little finger. You have to differentiate with the palmar deputed contracture. Deputed contracture. This contracture is different than the Bischoff deformity, where deputed contracture there is a cord-like tightness, unknown cause and cord-like tightness. This is the category of the deputed contracture. In the ulnar nerve, you will find Bischoff and deformity. MMT, muscle supplied by the ulnar nerve is weak, sensory assessment, and basically special test is positive elbow flexion test, because here elbow involved, tenal at the medial epicondyle, and ULTT. Again, ULTT is a broad terminology. Little bit I'm giving you the idea about the ULTT. So ULTT, which give the idea where the nerve is getting tension. We have a ULTT 1 and 2 for the median nerve, 3 for the radial nerve, and 4 for the ulnar nerve. Easy remember point of view, if elbow and wrist both are in extension, it causing the tension on the median nerve. Elbow is extended, but wrist is flexed, that is your radial nerve. And elbow is flexed and wrist is extended, that is your ulnar nerve. So that way, you're gonna remember the ULTT. Again, peripheral nerve injury, I will explain about the nerve gliding technique, nerve flossing technique, that technique they may ask. But right now, just get the little idea. If you want to get the median nerve stretch, you are going with neck side deviation, shoulder depression, shoulder abduction, either 10 degree or 110 degree, elbow extension, wrist extension. Okay? And you may get the question like this. So most appropriate position which mobilize the radial nerve. So radial nerve is mobilized with the elbow extension, wrist flexion. Elbow extension and wrist extension, no. Elbow extension, wrist flexion. So answer is 4. And result of which of the following nerve tension is most likely to be positive for waiter who has the hand pain when carrying a tray overhead. So he is using elbow flexion and wrist extension. This is the position for which nerve?
Median, no? Allah, no, sir.
Ulnar. So this is the ulnar nerve. Let's go with the question. So MMT of the patients who has gunshot injury superior to the elbow joint. See the word superior to the elbow joint means pronator teres is affected now because superior to the elbow. If pronate at the pronator teres level, then pronator teres is normal. Superior to the elbow, pronator teres and pronator quadratus both are affected. Okay, I'm just giving the knowledge. Superior to the elbow, having a partial median of injury. Intervention for this patient include strengthening of wrist flexion and forearm, basically pronator teres and pronator quadratus, supplied by the median nerve. Supinator is supplied by radial nerve. So this 3 and 4 is out of the question. Now pronation, finger flexion, both are correct. Thumb adduction and thumb opposition. So thumb adduction is done by the adductor pollicis, which is supplied by the ulnar nerve. So the answer is 2. Clear, everyone? Particularly peripheral nerve injury, again, it's a vast topic, but little idea. So goal of the treatment is getting the awareness, prevent secondary complication, and allow the recovery of the nerve. There is a one question, what is the recovery rate? So recovery rate is 1 mm per day. And you have to prevent the contracture. So you are using the splint. Okay. So wrist splint you're gonna use for the median nerve. Reduce the pain and inflammation, appropriate positioning, prevent the tightness and contraction of the intrinsic muscles, stretch the tight muscles, strengthen the affected muscles, and go with the task-specific training. This is the broad. In your exam, when we are conducting peripheral nerve injury, we have to go with the too much detail with each component. But right now we are preparing for the elbow joint. There is a MSK topic. You should know which muscle is involved if there is a peripheral nerve. Okay. This is a table given in the therapy aid, basically. I just want to giving you the idea that whenever you are going with the MSK, so particularly elbow flexion, elbow extension, you should know about the reflexes and the cervical, because you have to differentiate cervical radiculopathy versus elbow condition. So that way, just get the idea. Basically, the cervical one I'm conducting with the cervical spine, but this is the important stuff just for your knowledge. I just put it the screenshot here, but that is the thing that you have to go through that. You should go through that here. Special test of the elbow, lateral epicondylitis, medial epicondylitis, Tinel sign, pronator teres syndrome, and ULTT. ULTT for median nerve, ULTT for ulnar nerve, ULTT for the radial nerve. So these are the special tests. You should aware about that. And so this is the almost mini portion is done. Any question? So far you understood anything that you feel like, okay, I have a difficulty to understand? Okay, and now this is the specific. It's like, you know, it is not specific. It is like rare conditions. Rarely you end up with a question, but it's you should aware about that. Osteochondrosis of humeral capitulum. That is the avascular necrosis. Actually, avascular necrosis of the hip that we know, right? Same thing, almost like similar like that. The osteochondral bone fragment become detached from the articulating surface, convert into the loose body in the joint, repetitive compression force between radial head and the humeral capitulum, and mainly it occurs age. So age is important. 12 to 15 years of age, patient having a problem with the capitulum. Capitulum is the humeroradial joint. So at that time, loose body formation, flexion is restricted. If you get this type of the question, one time think about osteochondritis dissecans. Another, sorry, it's my bad. Osteochondritis dissecans is the loose body Penner disease. Tanner disease, it is the avascular necrosis of capitulum. It is lack of the blood circulation leading to the fissuring and softening of the articulating surface. Etiology is unknown, and this is happened 10 or less. So here also age is important. If the child is 10 years below, high chances of the Tanner disease. 12 to 15, osteochondritis dissecans. It is a rare condition, they may ask, but you should know. It is I can say it's just for the knowledge. We should have prepared ourselves for everything. You don't know whatever question come across. Good. And overall physiotherapy intervention. So if you have this condition, rare condition, you cannot do anything. You cannot change the vascularity. You cannot change the what I can say, bony formation, because it is an osteochondral bone fragment, detached. So here we have to go with the flow. Physiotherapy intervention include rest, avoid the throwing activity, loading activity, gymnastic activities, give the exercise in the pain-free range. Whatever muscles are there, we are going with the strengthening, flexibility exercise within a pain-free tolerance range, and slowly, if patient heal, it permit, slowly increase the intensity. But if symptoms persist, refer to the physician. It is not our task, surgical intervention. And surgical is the post-operatively, again maximum protection 4 weeks. But here again, there is no red flag, slowly increase the exercise. That way you're gonna go with the rehabilitation. Rare condition, just for your general knowledge. Good. In the athlete, you may end up with the ulnar collateral ligament injury. So ulnar collateral, it is on the medial aspect, which is leading to the valgus stress. Okay. So occurs due to the repetitive valgus stress. Clinically, ligament laxity. Patient may have an ulnar nerve injury. MRI, it is the diagnostic portion. Patient, clinical examination, instability in the joint, and basically surgeon is important. Physician is important here. They are giving medication. PC is not asking the medication. Physiotherapy, initially rest, pain management, and then go with that. Pain, inflammation is reduced. Strengthening exercise, focus on the elbow flexor strengthening, tapping for the protection, and then go with the return to the function. This is also the rare condition, but keep in your mind. Sports patient may end up with ulnar collateral ligament injury. Any questions so far? Mayuri, Rajvi, Purvi, Ravinder?
No, ma'am.
Okay, so this is your basic elbow joint. That arthrokinematics, small component, carrying angle, pulled elbow, medial epicondylitis, lateral epicondylitis, condition, identification, treatment, muscles, MMT they are asking, myositis ossification, peripheral nerve, and other conditions. So any of the topic you end up with the question. Good. So this is your basic idea about the elbow conditions. My next batch start approximately 25th June, around like that, 25th June or the 3rd week of the June for the regular batch. So if you have like, definitely you have my contact number. Feel free to contact me, and any PC related, any query, credential query, or any question answers, feel free to ask me. Good.
मैम
Yeah.
मैम ऐसे आप जो क्वेश्चन दिखाते हो मतलब तो वो हमको प्रैक्टिस करनी हो तो वो कैसे कर सकते हैं?
You like I'm giving the questions to the patient, like I'm preparing the student with the question answers that I can give, like we are forming the questions, like I'm forming the questions and then delivering, because in the PC this is like a scenario based, so you cannot like getting particular book. It is like scenario based, but generally I'm preparing my student with the question answer. There is not like Yeah, you are going with the therapy and in the, that is a book, but in that one, there is the question answer on the back of the book. That way you are getting it, few questions, but generally I'm preparing my students with the question answer.
Okay,
Good.
ma'am. Yes.
Okay, good night, everyone. Thank you to join and be in contact with me. Perfect. Bye.